Hi guys, good evening, good evening, good evening. Welcome to the BLS series. Today we'll be talking about thoracic trauma. Today this will be an extended session. We'll talk about various aspects in trauma. So today's discussion is predominantly based upon thoracic trauma. So in the primary assessment, I came up with a concept of immediately life-threatening and potentially life-threatening. So we spoke about what are immediate, what are potential. So I'm going to take each individual disorder and we'll try to discuss each one of them as we go across, right? So without wasting any further time, let's kickstart this session. And all those FMG students who are watching, we are doing a rapid revision series, that is your FMG decoded marathon. I've done the general surgery in the morning, that was around 11 to 2:30. Now we are taking another session for systemic surgery. That will be from night 10 to 12:30 or 1 o'clock, whatever the time might be. Okay, chalo. So without wasting any further time, we will dig into thoracic trauma. In the thoracic trauma, we'll be talking about 4 disorders for today. So I'll be discussing what is a tension pneumothorax, what is an open pneumothorax, what is a flail chest, and what is a pericardial tamponade, right? So our objective is to conclude tension pneumothorax. We'll talk about the open pneumothorax. We'll talk about the flail chest, and we'll talk about the pericardial tamponade. We're talking about the pericardial tamponade. Okay? Now, what is a tension pneumothorax, or what is the basic definition of a tension pneumothorax? So tension pneumothorax is defined as the word tension says, constant increase in pressure in a confined environment. Pneumo is air, thorax is in the thoracic space, right? Now, when you say tension pneumothorax, it is defined as, tension pneumothorax is defined as collection of air. It is a collection of air between the parietal pleura, and visceral pleura. It is a collection of air between the parietal pleura and the visceral pleura due to air leak within the thoracic cavity. So the air leaks within the thoracic space, and that is what we call as tension pneumothorax. So the source of air leak is within the thoracic cavity. It is called as tension pneumothorax. Now, what is an open pneumothorax? In an open pneumothorax, ignore the first part. We'll discuss it, why it is important or relevant. For now, you remember what is an open pneumothorax. Again, open means it is coming from outside. Pneumo is air. Thorax is the thoracic space. So it is defined as the collection of air. It is a collection of air again between the parietal pleura, and visceral pleura. Between the parietal pleura and the visceral pleura due to air entry from external environment. From the external environment into thoracic cavity, due to increased due to negative pressure, due to negative intrathoracic pressure, right? So open pneumothorax is defined as the collection of air between the parietal pleura and the visceral pleura due to air entry from an external environment into the thoracic cavity due to a negative pressure in the intrathoracic space. Hi guys, hi Nikhil, hi Mansoor. So when you say flail chest has 2 definitions. One is your ATLS definition, another one is your European guideline definition. We'll try to keep it simple. According to the ATLS definition, flail chest is more than or equal to 3 continuous ribs. More than or equal to 3 continuous ribs are fractured at more than or equal to 2 different sites. more than or equal to two different sites on the same rib. More than or equal to three continuous ribs are fractured at more than or equal to two different sites on the same rib is what we call it as flail chest. This is your ATLS definition. Another one that you have is more than or equal to two continuous ribs. More than or equal to two continuous ribs are fractured at more than or equal to two different sites. More than or equal to two different sites on the same rib. On the same rib is what we call it as flail chest. Right? So this is the definition of the flail chest. Ghanshyam, we will start the GIT when we are done with the trauma. Trauma will take another 2 weeks of session. Uske baad you have a long marathon of GIT starting all the way from the esophagus. We'll go into stomach, hernias, bowel, and then hepatobiliary, pancreas, and thereafter. Okay? Yes, we will. See, I told you it's a promise that I will finish every single topic that is there in Bailey. So this series will stand as a cornerstone. Whenever you want to read Bailey, you don't understand something, you come back here, you will find that video relevant for that point. Now, what is a pericardial tamponade? The pericardial tamponade is defined as the collection of, it is a collection of fluid or blood between the pericardium and heart. It is a collection of fluid between the pericardium and heart, resulting in inadequate systolic and diastolic contraction. Inadequate systolic and diastolic contraction of heart, causing obstructive shock. It's a form of cardiogenic shock that will present to you. Okay? So this is your pericardial tamponade. So we have 4 standard definitions of all the 4 disorders that you have. You have the tension pneumothorax, we have the open pneumothorax, the flail chest, and the pericardial tamponade, right? Now, when you look across, what is the mode of injury for development of all the following that we have done or said across? Now, for tension pneumothorax, it is usually seen secondary to the blunt trauma to thorax. It is because of blunt trauma to thorax. This is because of penetrating chest injury. This is because of penetrating chest injury. Now, because it sucks the air, it is also called as a sucking chest wound. This is also referred to as a sucking chest wound. Now, as it draws the air from the external environment, this is called as a sucking chest wound, right? Now, for your rib fracture, it has to be associated with blunt trauma to thorax. Pericardial tamponade can be seen secondary to blunt trauma to thorax. It can also be seen in penetrating chest injuries. It can also be seen in penetrating chest injury. It can also be seen in penetrating chest injury, right? So you have the blunt trauma to thorax, penetrating chest injuries, blunt trauma again in terms of your flail chest. Pericardial tamponade can be seen in both. It is going to be blunt trauma as well as penetrating chest injuries. Now we'll try to understand each of these mechanisms, which I take a great pride in explaining. So we'll be talking about how does the tension pneumothorax differ from the other components, right? Now, in order to understand the tension pneumothorax, we have to understand the basic anatomy. Let's say this is the thoracic space. This is the thorax that we're talking about. It's the thoracic space that you have. Within thoracic space, you're going to have lung. This happens to be the right lung that we have. and let's say this happens to be the left lung that you have, right? This will be centrally presented. This is the trachea. This is the right main bronchus. This happens to be the left main bronchus, and then it will further divide across. We're going to further divide across. Then you see the layer that is covering this lungs is what we call it as the parietal pleura. This is what we call it as the parietal pleura. This is the mediastinal pleura that is covering the mediastinal space, but it is in continuity with that of the parietal pleura. This is the parietal pleural space, right? Now, when you look at on the outer side, on the outer surface, you have this pleura. This is what we call it as the parietal pleura. The green one is your visceral pleura. The green one that is covering around the lungs is your visceral pleura, and one that is present around the chest wall, this is what we call it as the parietal pleura, right? So the basic orientation that we need to have, just for the sake of understanding, I will label them across as well. So this is what we call it as the parietal pleura. This is what we call it as the parietal pleura. The one that is lining the outer chest wall, this is what we, sorry, I've written ulta. This is your visceral pleura. This happens to be visceral pleura. This happens to be your parietal pleura. This happens to be your parietal pleura, right? So they have pleural space in there. So when we say there is a tension pneumothorax, in a tension pneumothorax, what is going to happen? There will be an injury within the thoracic cavity, let's say in the blunt trauma thorax, because of sudden increase in intrathoracic pressure. See, imagine lungs like a balloon, and you're inflating the balloons become bigger, right? Now, as you inflate, the balloons become bigger. Suddenly from outside, I just hit the balloon. What is going to happen? You're blowing the air, so the pressure from the inside is increasing. From outside, I've suddenly increased the pressure. What will happen? There will be a tremendous rise of pressure within that balloon, and that balloon will become kaboom, right? It just bursts open. Same thing is going to happen during the inspiration. Lungs try to expand. Suddenly, somebody hits you from outside. That compressive force on the thorax will cause your lungs to pop out. Now, once they pop, they are going to burst open. Now, when they burst open, this is how you would see the lung is injured, right? Now, once the lung is injured, you see this area is going to give away, right? This is the area which is going to give away. You see the lung is become kaboom here. Problem is, even the visceral pleura will also give away, right? So with every time the patient is going to breathe, during every inspiration, every single time the patient is going to breathe, as the air enters into the thoracic space, it will go into the lung parenchyma, and from there you will notice the air that is going to be here will start leaking out from this space. Now, as the air leaks out, where is the air going to collect? It is going to collect between the visceral pleura and the parietal pleura, and as more and more amount of air continues to go in, as more and more amount of air will continue to go in, you will see more amount of air is going to get accumulated. Now, as in more and more amount of air is going to get accumulated, this is what it is going to result in. You can see as more and more amount of air leaks out, it is going to fill up the thoracic space. Now, it is going to compress the entire lung per se. It is going to compress the entire lung per se. So what you see here, the lung is getting compressed. Here you say the lung is getting compressed because of the external force that is created by the collection of air itself. That is created by the collection of air itself. You now notice that all this air that is accumulated will start to exert pressure on the lungs, and this lung won't be allowed to expand. You now notice the lung is totally compressed. It won't allow the lung to expand. It won't allow the lungs to expand. So this air that is leaked from outside has compressed the lung on the same side and not allowing the lung to expand. This is what we call it as tension pneumothorax. Another interesting thing that you will notice is the trachea, which is supposed to be central in position. The trachea, which is supposed to be central in position, under the influence of this tremendous pressure, you now see the trachea is getting deviated. You see the trachea is now getting deviated to the opposite side. So as the pressure exerts more and more, you now know the trachea, it is going to get deviated to that of the opposite side. The trachea is going to get deviated to that of opposite side. So this is the basic pathophysiology of the tension pneumothorax. In the tension pneumothorax, you see the air leaking through its own space within thoracic cavity, gets accumulated because it is made up of bones, that is your rib cage. It won't budge much, so all that air that is leaked out will start exerting pressure onto the lungs, and the lungs will get compressed. The lungs are going to get compressed, and this is the basis of your tension pneumothorax. Now when it comes down to the open pneumothorax, let's understand how does it vary a bit, right? Nothing spectacular, but just the way you have to understand this. Now in an open pneumothorax, again the basic orientation remains the same. This is the thoracic cage. This happens to be the lungs. Right in the center, you have the trachea. The right main bronchus and the left main bronchus, which is here. This is the tracheal rings, which are present across here, right? Now, as I told you, the one that is covering the lung parenchyma is what we call it as the visceral pleura. So you can see the visceral pleura is here. It will be continuous with the mediastinal pleura, which will be here. Right, and then this is what we call it as the parietal pleura. So this is your parietal pleura that is present. Now in an open pneumothorax, I just told you that it is going to be a sucking chest wound. So let's say there is an injury to the thorax, right? Say there's an injury to the thorax and the injured thorax is opened up like this, right? Now this injury should be of a significant value and there should be a pleural breach also. That is the most important criteria that you're looking at. The injury should have significant size and there will be a pleural breach. Now that is why I told you, like if I take a small needle and puncture, and I stab with a small needle and bring it down, will it cause a open pneumothorax? The answer is no. So the criteria of developing an open pneumothorax, it should be either more than 3 centimeters in size or more than 2/3 of the tracheal diameter of that particular patient in order to create this one-way valve, and that is what we call it a sucking chest wound. Now because of the negative pressure, every time the patient is going to breathe, what is going to happen? The air from the external environment will be sucked inwards. Now this sucking of the air from the external environment has given its nickname, that is sucking chest wound. As more and more amount of air is going to pull out, what is going to happen? It is again going to get collected here. Now as more and more amount of air is going to get collected, it is now going to compress the lungs. It is now going to compress the lungs completely, right? Now as the lung is going to get compressed, you see here under this compressive force, you see the lung is getting compressed, and this compression of the lungs won't help, it won't allow much. So it won't have much for the patient to breathe across. Again, same thing, because of the excessive pressure that is exerted, you now see the trachea, which is centrally positioned, has to be deviated onto the opposite side. So you now notice because of excessive air that is getting collected, it is now going to cause the shift of the trachea onto the contralateral side. So it will be a tracheal deviation onto the opposite side. There will be this tracheal deviation that is present on the opposite side, and this is what we call it as your open pneumothorax. So you can see here, this is a tension pneumothorax. There is air leak within the thoracic cavity. This is an open pneumothorax where the air is entering from the outside. So hence it is open and there is an one-way valve. So because of the negative pressure, we all know this negative pressure inside the thoracic cavity has exerted or brought all the air into the thoracic space. and it will continue to suck as long as the pressure balances out. But by that time, the amount of air that is going to go in is enough to compress the lung, and hence, rather than having 2 lungs to breathe, the patient is only having 1 lung to breathe, and this is what we call it as open pneumothorax. This is what we call it as the open pneumothorax. Now, on the other hand, what do you mean by flail chest? Now, for flail chest, let's say this happens to be the suprasternal notch, and let's say this happens to be the sternum, right? And these are your thoracic vertebrae that we have, right? And let's say these are the ribs that are attached. Just for the sake of understanding, I'm just depicting the ribs here. So anteriorly it is attached to sternum, posteriorly it is attached to the thoracic vertebra. So these are the various ribs. Just for the sake of understanding, let's say this is the first rib, this is the second rib, this is the third rib, the fourth rib, and hereafter you will see the multiple ribs which are present, right? Now between these ribs, the lung is going to be here. In the mid-clavicular line, the extension of the lung will stay all the way to that of 6th rib. In the mid-axillary, it is going to go all the way to the 8th rib. In the posterior scapular line, or the mid-scapular line that you have, that is going to be at the 10th rib. So we have 6, 8 and 10. So 6 is center, 8 is in the mid-clavicular, posterior it is going to be 10. So the extension is maximum on the posterior side. Now you see there are muscles which are going to hold these ribs together, and these are what we call it as the intercostal muscles, right? These are the intercostal muscles which will hold the ribs together, and that is why they are going to act, even though the multiple ribs, they act as one singular unit because of these intercostal muscles. Because of this intercostal muscle. Because of these intercostal muscles, right? So you have the ribs, you have the intercostal muscles anteriorly attached to sternum, posteriorly it is attached to that of the vertebra, and then you can see it is acting as one single unit. It is acting as one single unit. Now I said the patient who is going to have a flail chest, there will be 3 continuous ribs fracture. So if I just consolidate our ribs, right? So this is your rib number 1, this is your rib number 2, this happens to be your rib number 3, and thereafter it is 4 here, 5 and 6. For the sake of depiction I've given. Now according to the definition, there has to be 3 continuous ribs which are fractured. There has to be 3 continuous ribs which are fractured, and each rib must be fractured at more than or equal to 2 different sides on the same rib. Now you can see there are 3 rib fragments which are fractured here. So this is one fragment of the rib. There's another fracture fragment which is here. And there's another fracture fragment which is here. Right? This is the definition of flail chest. Now why it is important for us to know is, you see, as I told you, when you look at the entire concept of your, the flail chest, I told you ribs have 2 attachments, right? Anteriorly you can see the rib is attached to sternum, and posteriorly you see that it is attached to these blocks. These are nothing but your vertebra, and that is why the ribs are anchored and they are able to move with respiration. They're able to move with respiration. Now if you look at these segments, that the flail segments that are created here, now in the flail segment, where is it attached to? Neither it is attached to sternum nor it is attached to the vertebra. It is freely floating, and that free floating fragment of rib is what we call it as the flail rib or the flail segment. The problem with the flail segment is, as we all know, during the inspiration there is a negative pressure. Negative pressure is a pulling force, but when there is a pulling force, the ribs does not move closer, they move away, which is because of bucket handle analogy, which I'll discuss in a bit. But you need to understand this free floating segment during inspiration, so lung is trying to expand, and because of negative pressure the flail segment compresses the lungs. Lungs try to expand, this compresses. Lung is trying to expand, this flail segment is drawing inwards, compressing the lungs. Hence every patient who has a flail chest is actually battling a disorder, a condition which is going to be quite fatal. So it's like an inner battle. The lung wants to expand, the flail segment does not want it to expand. So there's that tussle that is going. Let's see who wins. If you treat, intervene, the patient wins. Otherwise, the patient dies, right? So this is with respect to flail chest. So we understood what is a tension pneumothorax, what is an open pneumothorax, what is a flail chest. So the definition of flail chest is quite evident here. So in flail chest, more than or equal to 3 ribs which are continuous. Which are continuous fracture at more than or equal to 2 different sites. At more than or equal to 2 different sites. Okay? So that's the flail chest. Now coming your pericardial tamponade. Now when you take this as the representation of the heart, let's say this is the representation of the heart that you have. Now surrounding the heart you have the pericardium. So this is the pericardium. Surrounding the pericardium we have the normal pericardial fluid, right? So let's imagine that this is the pericardial fluid that is present. It is to prevent any frictional rubs between the heart and the pericardium. So this lubrication is important so that the heart and the pericardium do not fuse with each other. The heart and the pericardium do not fuse with each other. Now in a pericardial tamponade, you'll see this is the heart. In a pericardial tamponade, you'll see there is a collection of fluid between the pericardium and the heart. So heart gets compressed. The pericardium swells even bigger. So the pericardium is going to be like this. So the heart shadow is bigger, but the heart is getting compressed. And that is because of there is the blood. In this trauma, I would say blood, but it can also be fluid. So this is going to get accumulated here. And this excessive accumulation is now going to cause a compressive force. It's now going to cause the compressive force on the heart and won't allow the heart to relax, right? Now this compressive force on the heart, which is not allowing the heart to relax, is what we call it as a pericardial tamponade, right? So you can see this is the pericardium. And this happens to be the pericardial fluid. This happens to be the pericardial fluid, right? Now as more and more amount of fluid is going to get accumulated, it is going to compress the heart. Now as the heart gets compressed, it will not be able to contract and relax effectively, hence resulting in obstructive shock. And that is the problem that you're going to deal with your flail chest. So you have all the 4 major disorders in the thoracic injuries. You have the tension pneumothorax, you have the open pneumothorax, you have the flail chest, and you have the pericardial tamponade. Clear? Now let's look at that. How are they going to present to us clinically? So talk about the clinical features of each one of them, starting with the tension pneumothorax. So when you talk about the tension pneumothorax clinical features, so in a tension pneumothorax, the first thing the patient is going to experience, because the lung is going to get compressed, right? So you'll have compressive features. Now in a compressive features, what is going to happen? The patient is going to have dyspnea, that is difficulty in breathing. Now as there is difficulty in breathing and the patient has only one lung, so it is trying to compensate. How does it compensate? It starts breathing faster. So hence patient is also going to have tachypnea. So presence of dyspnea, there is presence of tachypnea. Along with that, patient will feel as if somebody is compressing the chest because of that air that is getting, compressed onto it, or the air gets getting accumulated into it. It causes a compressive force. It looks like as if somebody is hugging the patient tight. So there will be presence of chest congestion as well. So there is presence of dyspnea, there is tachypnea and chest congestion. That is the primary presenting finding of a patient with tension pneumothorax. Now obviously patient has come, so I would like to evaluate. So on examination, what do you see? Now on examination, because the patient is having difficulty in breathing, I will auscultate first and I would say there is reduced or absent breath sounds. there's reduced or absent breath sounds. Second thing you will notice, you will see the trachea deviated to opposite side. This trachea deviated to opposite side. So whichever side there is reduced air entry or absent breath sound, opposite to that side the trachea will be dilated. Now as all that air is going to get accumulated, it is going to exert pressure onto the head and neck veins also. They won't allow it to drain, so there will be distended neck veins as well. There will be distended neck veins as well. And when you do a percussion, you will see presence of a hyper resonant chest node, or I can say the hyper resonant chest node on percussion is present, right? So you have patient with dyspnea, tachypnea, chest congestion, and all these findings, that is absence breath sounds, trachea deviated to opposite side, distended neck veins, and hyperresonant chest node. We all know all these features of their reasons as well. Now, when it comes down to the open pneumothorax, patient will have same. There will be dyspnea, there will be tachypnea, there will be presence of chest congestion. But on examination, what you will see? You will see, number one, there's presence of a sucking chest wound. The presence of sucking chest wound. Apart with that, you will have all the other features. You'll have all this, that is decreased breath sounds, trachea deviated opposite side, distended neck veins, hyperresonant chest node. All this, the additional that you will see will be presence of sucking chest wound. Now, in order to understand the concept of the flail chest, you need to understand in the first place that why flail chest exists and what is its impact. So I will take a small explanatory component here. If you think in normal sense, right, during inspiration within the thorax we have negative pressure. Now we all understand negative is a pulling pressure, not a pushing pressure. So under the influence of negative pressure, the air is being pulled inside. That is understandable. My question to you is, under the same influence of negative pressure, why are the ribs not pulled forward? Or why are the ribs not pulled inwards? In fact, the ribs are moving away, providing the space for the lungs to expand. So during inspiration, it has a negative pressure. Under the influence of negative pressure, I would expect the ribs to move closer to the lungs, but it does not. It moves away from the lung. What is it changing? What is it that changes? ऐसा क्या है जो बदल रहा है? Any idea? Right. So in order to understand the whole concept, you need to understand a small analogy, which is your bucket handle analogy. So let's understand what is this bucket handle per se. Now to understand the bucket handle, let's say that this is the bucket that we're talking about. I'm going to equate to each single component. So this is how the bucket would look like. Now let's say this is the bucket handle. So the handle is fixed at two ends. So this is the bucket handle that we have. And then behind the handle, let's say it is you who are sitting, and I will say that you are sitting behind the bucket. You are holding the handle from both the ends and you're trying to pull the handle towards you. Now, when you look at this bucket handle analogy, what is the prospect of it? All right, so in a nutshell, what is the similarities that we're going to draw with respect to thoracic space? Now, this area that you're able to see, this is your intrathoracic space. This area is the intrathoracic space. The handle that you're able to see, this is equated to ribs, and you are the negative pressure. You are the negative pressure. So you're sitting behind the bucket and you're trying to pull the handle towards you, and that handle which you're trying to pull towards you will create a negative pressure. Right? Now, as this is going to happen, you will see that what is going to happen. As you exert more and more amount of pressure, the handle will now start to move. Now, as the handle starts to move, you need to understand the journey of the handle. The fixed positions will remain, it will not change. But initially the bucket handle, which was here, initially at rest the bucket handle was there. You started exerting pressure. the handle has now started to move. Now as you exert more and more amount of pressure, the handle will continue to move and it will move to its maximum extent, or I can say this movement of the bucket handle will continue to happen as long as you exert pressure. If you have more pressure, I mean if you have more power, you can get the handle to the other end also. But if you have only this much amount of power, you hit and then you low, you hit and you low. That means you're only able to pull a bit and then you are leaving it, right? That means it's only so I would like to tell you that the negative pressure is enough to pull the bucket handle from its resting position to here, and then it drops back. But in this, what has happened? So you see, you are here, you are sitting behind the bucket, you are pulling the bucket handle, you're pulling the bucket handle towards you. So the negative pressure is still maintained, right? Now because of the negative pressure, the bucket handle, which is your rib, is now being displaced. Now the thoracic space is made up of ribs only, no? Right? So to be very honest, this rim is hypothetical. So this end of the rim, I would say, imagine that this does not exist. Right? So the thoracic space is made by ribs only. Now as you have moved, what has happened? The rib has moved far away. Now as the rib has moved far away, what did it do? It has now increased your intrathoracic space. See, this is an increase in intrathoracic space. So what does it allow? It allows the lung, which was initially here, which was only this much, right? During inspiration, it is now allowed the lung to expand, and this expanded lung is getting its space because of this bucket handle movement. So for the sake of understanding, just because I don't want you to miss out, this is how the bucket was created. This is how the bucket was supposed to be here. But again, because the ribs have moved, the intrathoracic space has increased, allowing the space for your lungs to expand. And this is your beautiful bucket handle analogy, which is trying to tell you that even though there's a negative pressure, it is not the ribs that are going to move closer. It moves away from the lungs, so that providing lungs its space to expand. And this is your bucket handle analogy. Now, how do you put that perspective into our flail chest? So in the flail chest, what is happening? In the flail chest, the rib is getting fractured. Now, if the rib is getting fractured, needless to tell you, you're smarter than me, you'll be able to figure it out. This is the bucket that you have. And then this is the rib that is present. And you, my friend, are the negative pressure, the sole force behind the entire movement of the ribs. You are the negative pressure that is there. And this is the lung that is present here. Right? Now, in a flail chest, the problem is the rib is broken at two different ends. Right? Now, you have a broken, fragmented rib. You have a broken, fragmented rib that is present. Now, as you exert negative pressure, the negative pressure remains uniform throughout its distribution around the rib cage. So here you will see the negative pressure. Also, the negative pressure will be here on this fragment of rib also. Okay. So during inspiration, what is going to happen? Everything is going to be in the same context, but during inspiration, you see as the ribs will start to move closer. This is the bucket handle that you have. The bucket handle which is present here, it is fixed, and this moved like this. See? You can see this has moved in this particular fashion. Initially, this was supposed to be at this particular location. This was the resting location of the handle, but slowly it has moved and has reached to this particular point, right? Now, but as I told you, it is fractured. So this is the fractured segment. Now, because the fractured segment, you will notice that this end of the rib is neither attached to the sternum or to the vertebra. In that matter, this part of the bucket handle is neither attached to the left or the right side. Now, what is going to happen? During inspiration, obviously the lung will now start to expand. Now, as the lung starts to expand, and this expansion occurs because the air is filling up, and negative pressure is the one that is pulling. Negative pressure is the one that is pulling the ribs away, right? So you are the negative pressure, you're sitting here. You're holding one end of the handle here, another end of the handle here, you're pulling it. So hence these movements are justified. But again, there is a third force which is present on this fragment. Now, as this fragment is going to be pulled under the influence of negative pressure, you will see that this fragment will not remain here. So what is going to happen? This fragment is now going to go. This fragment is now going to go, and it is going to move inwards. Now, as this fragment moves inwards, this indrawing of the fragment. This indrawing of the fragment is now going to create a compressive force on the lungs. Now, this is creating a compressive force on the lungs, not allowing the lung to expand. It is not allowing the lung to expand. So during inspiration, the lung is trying to fill up with air. The lung is trying to expand. This flailed rib is trying to compress. Lung tries to expand, this ribs try to compress it, and there is a war between these two. Now, in order to breathe further, what is going to happen? The patient has to breathe with greater force, use axillary muscles to pull this flail rib backwards so that the ribs, or I can say lungs, can fill enough amount of air and expand. And this is the basic concept of your flail chest. Okay? Is that clear? Now, this indrawing of the rib during the inspiration is what we call it as, this phenomena is what we call it as paradoxical breathing. So during the inspiration, we expect the ribs to move away. We expect the ribs to move completely away, but here you see the ribs are drawn inwards, and this indrawing of the ribs is compressing the lungs, and this is what we call it as paradoxical breathing, and this is a characteristic of your flail chest. This is a characteristic of your flail chest. Clear? Great. So this is with respect to that of your flail chest as well, right? Now, in the flail chest, what is the clinical presentation? In the clinical presentation, the patient is now going to present to you with paradoxical breathing. Patient is going to present to you with paradoxical breathing. Now, in the paradoxical breathing, there is indrawing of the flail fragment. There is indrawing of flail fragment of rib. Flail fragment of rib during inspiration. This indrawing of the flail fragment of the ribs during inspiration, that will create a paradoxical breathing, right? Now, because of paradoxical breathing, what is going to happen? There will be increased work for breathing. Now, this increased work is usage of accessory muscles of breathing. Now, problem with the accessory muscles of breathing is, accessory muscles of breathing are skeletal. They are scalene muscles, the diaphragm, the intercostal muscles. All these are skeletal muscles. So, after a point, because of that excessive use, they will have fatigue. Korean cycle will kick in, and they will become difficult to use. So, that fatigue will now result in painful breathing. So, here with every single breath, the patient is going to draw. It is going to hurt the patient bad, and that hurt will cause severe pain. So the painful breathing. Patient continues to breathe, and there will be a point where he says it is better not to breathe because the pain becomes so excruciating. So here the patient will stop or becomes, starts to breathe lesser, and they will drift into respiratory failure. They'll go into respiratory failure. And from respiratory failure, it will end up into ARDS, and the ARDS will lead to the death of the patient. Right? So paradoxical breathing resulting in excessive work or increased work for breathing, causing a painful breathing, respiratory failure, and ARDS. The whole culprit in this, no, I cannot change the flail segment because it is the presentation. Patient will have this. To compensate, the body will cause an overworking. They'll be using axillary muscles. The only thing that I can address is pain. If I take the pain out of this picture, no. So there is no pain, patient continues to breathe. If patient continues to breathe, there's no failure. If there's no failure, there's no ARDS, no death. So single most important thing to be addressed in a patient of flail chest is going to be a painful breathing. It is going to be your painful breathing. Okay? So that is on the flail chest. Now, in a pericardial tamponade, as there is excessive amount of blood is being accumulated, there will be an inadequate systole, inadequate diastole. So that can be remembered with a triad that is called as a Beck's triad. Now, as the heart is getting compressed, because the heart is getting compressed, it will not have enough space for the blood to accumulate. So the preload in the left ventricle will decrease. If preload decreases, the cardiac output decreases. Cardiac output decreases, it will cause decrease in systolic blood pressure. So hence the patient is going to have hypotension. Along with hypotension, when you auscultate, because there is, see the heart sound and loved up sounds are because of the intensity with which the valves close and open. The intensity of valve closure and opening depends upon your end diastolic volume, because as the fibers of the left ventricle stretches and then the recoil pressure generates more, it will cause more pressure for the valves to open up. That is your Starling forces, right? Now, because there's less amount of volume, obviously the intensity which the valve closes and opens also decreases. And Yatan, I didn't get your question, beta. कर लूँगा मैं, अब नहीं हो रहा है सब पढ़ाई. बेटा पढ़ना तो पड़ेगा यार, और शॉर्टकट नहीं है. समझोगे तो पढ़ लोगे, क्या टेंशन है, ठीक है. So here, because the intensity of the heart valves are decreasing, it will result in muffled heart sounds. It will cause muffled heart sounds, right? And the third one that you have, so you have the hypotension, you have the muffled heart sounds, and the third finding that you have is going to be raised JVP. Now that raised JVP, because the blood is not able to fill up into the heart, so hence it starts pulling up, hence there will be raised JVP. That's your Beck's triad. Okay? So this is how you know you're dealing with open pneumothorax, tension pneumothorax. Are you dealing with that of the pericardial tamponade, or are you dealing that with the flail chest? Now when it comes down to investigation, for all chest modalities, remember tension pneumothorax is a ticking time bomb. I do not have much time to waste here. It is going to be our clinical examination. It will be our clinical examination. Here you have to patch the chest wound. Patch the chest wound and then perform a chest x-ray. Patch the chest wound and chest x-ray has to be done. That is for open pneumothorax if the patient is stable. For flail chest, it is your chest x-ray is the investigation that you need to do. In a pericardial tamponade, you have to perform the ECG, which will give you a low voltage current. We call it as low voltage ECG will be present. Along with that, you can also go ahead with 2D echo, which will tell you about the heart movement, the collection, fluid and all that can also be visualized. See? Now, how would you like to manage? Now, in terms of management, I'll talk about both open and the chest wounds. I mean, open pneumothorax and tension pneumothorax. As an emergency management, I would like to do a needle thoracocentesis. I like to do a needle thoracocentesis. Now, in the needle thoracocentesis, what needle would you like to use? I would use a 14 gauge needle. It's a wide bore needle. And in an adult, where would I insert it? I would insert in the 5th intercostal space of the mid-axillary line. If it is a child, then I would insert in the 2nd intercostal space of mid-clavicular line. So in an adult, I will put in the mid-axillary line. In a child, I will put in a mid-clavicular line so that the air can be vented out. That is on emergency basis. But if you say what is a definitive line of management, in a definitive line of management, I would like to go ahead with ICD placement. ICD is going to be the intercostal drain. ICD is going to be an intercostal drain. So when you talk about the ICD, in an adult in trauma, the preferred one is a 28 French. and in a child the preferred one is going to be an 18 French, right? Adult you can put a 28 French, and a child you can put an 18 French, right? Now where would you put it? You have to insert it something called as the safety triangle. Safety triangle is a triangle which is the safe side for insertion of the ICD. So you have the anterior border, the posterior border, and the inferior border. Anteriorly, it is formed by the pectoralis major muscle. Posteriorly, it is formed by the latissimus dorsi. Inferiorly, it is formed by the sixth rib. And the site where you would put the ICD. ICD will be placed in the fifth intercostal space. So ICD placement will be in the fifth intercostal space. It will be a fifth intercostal space. The same thing you're going to do it for your open pneumothorax as well. Now when it comes down to your flail chest, strapping, splinting, all these are contraindicated. You should not do so. So here the first step will be your adequate analgesia. It is the adequate analgesia. So in adequate analgesia, you can start the patient on a thoracic epidural analgesia. So that is the current guideline that you go for flail chest. If the patient is already in a respiratory failure, then I would go with IPPV, that is an intermittent positive pressure ventilation. It is an intermittent positive pressure and intermittent positive pressure ventilation. And IPPV will be an intermittent positive pressure ventilation. So adequate analgesia is the first line management. If patient goes into respiratory failure, then I have to intubate and then do an IPPV. Now when you talk about the pericardial tamponade in an emergency setup, you can do a needle pericardiocentesis. You can perform a needle pericardiocentesis, right? So what is this needle pericardiocentesis? You're going to take a wide bore needle. Again, a preferred one will be a 14 gauge needle. I will put in a subxiphoid region at an angle of 45 degrees, pointing towards the left shoulder. Pointing towards the tip of left shoulder. Pointing towards the tip of the left shoulder. Pointing towards the tip of the left shoulder. You can see here. So this is subxiphoid at an angle of 45 degrees, and we're pointing towards the tip of the left shoulder, right? Pointing towards the tip of the left shoulder at an angle of 45 degrees, you're going to insert it. Again, now it is questionable whether to do a pericardiocentesis or not, because the definitive management is pericardiotomy. The definitive management is going to be the pericardiotomy. The definitive management is going to be the pericardiotomy, right? So this is how you're going to manage your injuries in the chest, right? So all these are important injuries. We covered tension, we covered open, we covered flail chest, and we also covered pericardial tamponade. Okay. So with this, we're going to end the session here for today. Thank you so much for joining. Any questions, any queries, you know where to reach out. If you have any queries pertaining to surgery, questions, or you have any topic that you do not understand, or any personal query, you can reach down to me on the Instagram. This is the surgery guy. So feel free to reach out. This is the page that you have in both Instagram as well as Telegram. It is by my name only. It is Dr. Sandeep Reddy. Right. So any questions, any queries, do let me know. Otherwise, thank you so much for today. We'll resume back next week with another series of BLS. Thank you. Signing off.